Yes, good evening, everyone. And I think let's start. It's almost 8:40. So thank you for joining in. Thank you to the Pollen team for inviting. We're going to talk about carbapenem resistant Klebsiella and E.Coli. So let me get straight to the point. This is our data from almost 1 year ago, and these are numbers from the ICU. So look at Klebsiella and look at E.Coli. When you talk of Enterobacteriaceae, you talk of Klebsiella, E.Coli, Enterobacter, Citrobacter, and so on. So look at the carbapenem resistance numbers. Almost 50% of our ICU bacteremia from Klebsiella is carbapenem resistant, and around 20% of the E. coli is carbapenem resistant. Now, if you talk of Pseudomonas and Acinetobacter, the other two important organisms, we have almost a 90% carbapenem resistance for Acinetobacter. And this is not just in our settings. I'm showing you data from our own center in Pune, but it's not just from our settings. It's from the ICMR data as well that you will see these numbers. So usually you would see about a 40 to 50% resistance for carbapenems for Klebsiella, especially for hospital-acquired infections. Around 15 to 20 in most setups for E. coli. And again, you will see more than 90% for Acinetobacter and more than about 20% for Pseudomonas. So if you look at E. coli and Klebsiella, which we are going to be talking about this evening, we are going to be talking about Enterobacteriaceae. So I'm not going to be talking about the non-fermenting organisms like Pseudomonas, Acinetobacter, and so on. So if you look at gram-negative bacteria, these basics are important to understand because that forms really the basis of how we interpret enzymes and how we select antibiotics based on the enzymes. So if you look at beta-lactam antibiotics, these beta-lactam antibiotics enter through what are known as porin channels. And once they enter through these porin channels, they bind to the penicillin binding proteins. And that is where they disrupt the cell wall formation. So there are different classes of penicillin binding proteins. And broadly, you can say that it is PBP1 to 5. And every beta-lactam binds to different PBPs. So for example, Astionam will bind to PBP3 and so on. So you will have a beta-lactam trying to disintegrate or disrupt the cell wall formation by interfering or binding to the penicillin binding proteins. Now along this pathway, there could be resistance at various steps. So one could be that the porin channel itself could be modified. So you see the red porin channel there, that's modified. And that's why my beta-lactam antibiotic is not able to enter at all. A problem that we have started increasingly seeing in Klebsiella. And it was always there in Pseudomonas, but recently we have started seeing it increasingly in Klebsiella. And pretty much world over, there is concern about porin channel modifications in Klebsiella, especially in the presence of carbapenemase enzymes. Now, if you look at efflux pumps are acting in the direction opposite to that of the porin channel. So while the porin channel facilitates the entry of the beta-lactam antibiotic, the efflux pump actually facilitates the exit of the beta-lactam antibiotic. And then you have beta-lactamases. So what are beta-lactamases? Beta-lactamases are enzymes that are going to destroy or hydrolyze our beta-lactam antibiotics. And then last but not the least, you could have modifications in the penicillin binding proteins, so PBP3s. So if there is a modification in the penicillin binding proteins, then again our beta-lactams are not going to act. So what do we mean by our beta-lactams? Those are our penicillins, cephalosporins, carbapenems, and the monobactam Astionam. I'll be talking about some basics as well. So what are the beta-lactamases? So beta-lactamases, there are various ways of classifying the beta-lactamases. One simple way could be looking at the substrate that these enzymes act on, or the kind of beta-lactams that these enzymes hydrolyze. So then these could be penicillinases, or it could be cephalosporinases, or they could be carbapenemases. So those that hydrolyze penicillins would be known as penicillinases, and cephalosporinases if they hydrolyze cephalosporins, and carbapenemases if they hydrolyze carbapenems. Now there is a special class which is known as AMP-C, and these AMP-C enzymes are inducible. So or could be inducible. So what do we mean by inducible? Once the bacteria see a beta-lactam antibiotic, then these AMP-C enzymes are expressed. So we'll try and talk a little bit about each of these enzyme classes. This is a more formal way of classifying these enzymes. So most labs use what is known as the Amler's classification for classifying the enzymes. And here they are classified into various classes, class A, B, C, and D. Each class has various enzymes. So we could go on and on. Enzymes itself could be a 3 or 4 day long conference. But what is important to know is that which are the important enzymes in clinical practice. So these are the important enzymes when it comes to Enterobacteriaceae. So like I said, I'm not going to be talking about Pseudomonas or Acinetobacter this evening. We're going to be talking about how to treat carbapenem resistant E. coli and Klebsiella. So if you look at our E. coli and Klebsiella, these are the main enzymes that our E. coli and Klebsiella produce. So out of these 6 enzymes, 3 are carbapenemases and 3 are ESBLs. So it's easier to remember it like that. 3 are ESBLs and 3 are carbapenemases. If you look at the ESBLs, we have CTXM, SHV and TEM. You might wonder why do they get such names? So the nomenclature is variable. It sometimes depends. So CTXM gets its name for cefotaxime because it has very high hydrolytic properties for cefotaxime. It is the main ESBL pretty much world over. Now there are many different subclasses of CTXMs, and I won't really bore you by going into the details of CTXM. But we must remember that a lot of our ESBL isolates are actually producing the CTXM enzyme, and it is able to destroy all the penicillins, all the cephalosporins, and even the Monobacterium aztreonam. In fact, it has very high hydrolytic abilities as far as aztreonam is concerned. What it spares is the carbapenems. Although there are occasional reports of ertapenem MICs being raised from CTXM, what it truly spares is carbapenem. So it is not a carbapenemase, as the name suggests, it's an ESBL enzyme. So it is an extended spectrum beta-lactamase. So CTXM is our commonest ESBL, and it is something that is seen widely all across the world. There are many subtypes. There are 5 groups of CTXMs actually, and there are many subtypes. CTXM 15 is something that is very common in India, and it is notorious because not only does it have very high hydrolytic properties for aztreonam, sometimes it can also mutate, and I'll come to these details a little bit later on. So CTXM is the most important ESBL. Rarely they also produce SHVs and TEMs. So SHVs and TEMs are also similar to CTXMs, and these are ESBLs which are produced by Enterobacteriaceae largely. Now, if you look at the carbapenemases that these organisms produce, then there are 3 main ones: KPC, NDM, and OXA48. So KPC is a class A carbapenemase which is produced by E. coli and Klebsiella. It is very rare in the Indian subcontinent. In the last 400 carbapenem resistant isolates that we have genotyped in our center, we found only one KPC producing isolate amongst the carbapenem resistant ones, of course. So in the last almost 5 to 6 years now, it has been that we've been genotyping these isolates, and we have found only one KPC producer. So KPC is a very rare enzyme over the Indian subcontinent. Of course, there are more reports of KPCs from the northern part of the country, but by and large, it is a sporadic enzyme. So India is not KPC is not endemic as far as India is concerned. It is endemic in North America. So KPC is not something that we see very commonly. The NDM, or the New Delhi metallo-beta-lactamase, is something that we see very commonly in the Indian subcontinent. Now, this is a class B enzyme, and it is a metallo-beta-lactamase. So what do you mean by metallo-beta-lactamase? These are zinc-based enzymes, unlike the other classes which are serine-based enzymes. And what is special about NDM? What is special is that up until now, we have not had a beta-lactamase inhibitor that is able to destroy or inhibit the New Delhi metallo-beta-lactamase. Unfortunately, it is very common. More than 50% of our Klebsiella, which is carbapenem resistant, I'll show you my own enzyme data later on, but more than 50% of our Klebsiella, which is carbapenem resistant, and more than 70% of E. coli, which is carbapenem resistant, actually produces the New Delhi metallo-beta-lactamase. So we cannot but not know about the New Delhi metallo-beta-lactamase if you're practicing in India. And then we have the OXA48. Again, OXA48 is a family. It's not just one enzyme. So there are many OXA48 like enzymes that we have. It's a class D enzyme, and it's a carbapenemase. And that is also very common in our Indian isolates. So if you look at the enzymes which are produced by Klebsiella and E. coli, we have 3 carbapenemases there: KPC, NDM, and OXA48, out of which KPC is epidemiologically rare in the Indian subcontinent. And we have 3 ESBLs, which are CTXM, SHV, and TEMs. CTXM is the most potent ESBL out of these, and out of the carbapenemases, definitely NDM is the most potent. Now, just like we have beta-lactamases, we also have beta-lactamase inhibitors. So if you talk of clavulanate or sulbactam or tazobactam or avibactam, and then the newer ones like Turdobactam or Zidibactam, Taniborbactam, Zeruborbactam that we are going to soon have. So these are the BLIs that we have in clinical practice. Right now we have only 4 BLIs which are available in India. It is Clavulanate, Sulbactam, Tazobactam and Avibactam. In fact, 5 now we have Enmetazobactam as well. So if you look at these BLIs, then how do they fare against these enzymes? So if you look at KPCs, then the only BLI that we have in clinical practice in India, of course, they have Relibactam and Vavobactam in the US, but in India, out of the beta-lactamase inhibitors that we have, only Avibactam is able to inhibit the KPC enzyme. If you talk of the OXA48 again, out of the BLIs that we have, only Avibactam is able to inhibit the OXA48. Now, I'm not going to go into the oxas of Acinetobacter because those are not inhibited by Avibactam, and like I said, we are going to be focusing on Klebsiella and E.Coli tonight. But if you look at the if you look at Avibactam, then it is able to inhibit OXA48. It is able to inhibit KPC, unlike Tazobactam. Now, NDM is unfortunately not inhibited by any of the BLIs that we have in clinical practice. Taniborbactam perhaps is going to be the first one that we'll have access to amongst all the BLIs that are able to inhibit the New Delhi metallo-beta-lactamase. So if you look at the NDM, then again, neither Tazobactam, Avibactam, Relibactam, Vavobactam, of course not Clavulanate, Sulbactam, and Enmetazobactam, none of them are able to inhibit the New Delhi metallo-beta-lactamase. And if you look at ESBLs, then Tazobactam and Avibactam as well as Enmetazobactam, pretty much all 3 of them are able to inhibit the ESBLs. Of course, the most potent out of these 3 are Avibactam and Enmetazobactam when it comes to the class A ESBL. So if you talk of CTXM, SHV and TEMS, then Avibactam and Enmetazobactam are more potent inhibitors than Tazobactam. So this is in a nutshell the enzyme spectrum of E. coli and Klebsiella. And as you can see from this figure here, Avibactam is able to inhibit class A ESBL. So what are class A ESBLs? Those are your TEMS, SHVs and CTXMs. It is not able to, of course, inhibit the New Delhi metallo-beta-lactamase. It is able to inhibit AMCs for the most part. Of course, there will be rare AMCs, which I won't go into the details right now for the lack of time, but there are rare AMCs that can escape Avibactam inhibition. Then you have OXA48, which can be inhibited by Avibactam, and of course, class A carbapenemases, of which KPC is the most important, but there are others as well, which are inhibited by Avibactam. So if you look at a blood culture like this is Klebsiella from blood cultures. Now you can see here that it is resistant to almost all the antibiotics that have been tested. So which enzyme is likely to be involved here? So here you will agree with me that this is a carbapenem resistant isolate. Meropenem and ertapenem both are resistant. So it is very highly likely that it is producing a carbapenemase. Now let's go back to our figure here, which are the carbapenemases. So it's either producing a KPC, NDM or an OXA48. Now if it would have been producing only the KPC or OXA48, what would have been different here? Ceftazidime avibactam would have been susceptible, but ceftazidime avibactam is resistant. So that means that it is highly likely that this isolate is producing the New Delhi metallo-beta-lactamase. But if it would have been producing only NDM, now one interesting thing about NDM is that it spares aztreonam. So if it would have been a pure NDM producer, which means that it would have been producing only the New Delhi metallo-beta-lactamase, aztreonam should have been susceptible, because NDM is able to hydrolyze all penicillins, all cephalosporins, except cefderichol now, but all penicillins, all cephalosporins, and all carbapenems, but not aztreonam. So it is able to hydrolyze all the beta-lactam antibiotics except aztreonam, which means that it is very likely that I have multiple enzymes being produced. So it is very likely that this isolate is producing multiple enzymes. So in our setup, very commonly we have multiple enzyme production. So how do you approach such an isolate? So how do you approach carbapenem resistant Klebsiella and E. coli? Again, this is the enzymatic data that I have talked about, which we had published, I think, a couple of years ago now. It was in 2023. So like I said, Klebsiella is commonly producing more than 50% of Klebsiella in our setup produces NDM, and more than 70% of E. coli in our setup produces the New Delhi metallo-beta-lactamase. So one way of knowing, how which enzyme is produced is a PCR based test. So you must have seen many of these panels. BioFire is something that is commonly used in many of the hospitals. We use something known as the sepsis flow. Now, the ideal time that I want to know the enzymatic production is, of course, before I have the culture susceptibility report. Once I have the culture susceptibility report, then this becomes more of an academic exercise. So that is why I want to have access to the genotype. This is the genotype, which enzyme is it producing, before I have access to the phenotype. So this is a phenotype. This is a phenotypic report wherein the individual susceptibilities are given. This is a phenotypic antibiogram. So which means that I have access to the actual susceptibilities. Now, ideally, before this, I would want to have access to something like this. So this is the genotype. So understand the difference between a phenotypic report and a genotypic report. Which is the best time to perform a genotypic test? The best time to perform a molecular test is once growth is detected. So how does this process work? When you send blood cultures to the lab, these blood culture bottles sit in automated machines, and there are certain chemical reactions based on which they will detect the growth of organisms in blood culture bottles. Once growth is detected, what happens is that these are taken out, then the gram staining is done. That is when the lab will call you and tell you, whether your patient's blood culture is growing a gram positive organism or a gram negative organism. And then they are subcultured. So what do we mean by that? We provide these organisms good conditions to grow in. Why? Because we want to have enough growth for us to do the susceptibility testing. And we also want to do some other identification tests, but we also want to do susceptibility testing. So which means that from the moment growth is detected and the lab calls you and says that, your patient's blood culture is growing, let's say, a gram negative organism, from that moment onwards to actually getting the phenotypic report in your hand. This is the phenotypic report. This takes at least about 48 hours in most setups, and this time does not reflect on the efficiency of the lab. This is the time taken by the organisms to grow in subcultures and then for the antimicrobial susceptibility test to be carried out. Of course, automation does help it to a certain extent, but beyond a limit, this process cannot be accelerated. So, in the best of microbiological laboratories, it takes at least 48 hours from the time growth is detected. Now, understand this, from the time growth is detected, not from the time blood cultures are sent. From the time growth is detected to actually getting the phenotypic culture susceptibility report in your hand, it takes at least 48 hours. And this is the time that we are trying to optimize. So if at this point of time I run an enzymatic panel, then I might know that this gram negative organism is, so like this panel is telling me here, organism detected is Klebsiella, because a microbiologist can only tell you that this is a gram negative organism. He can't tell you just looking at the gram stain whether this is an E.Coli or a Klebsiella or an Enterobacter. Some of the organisms he might be able to tell you that it's maybe looking like an Acinetobacter, but at that point he cannot tell you for sure what the organism is. He can only tell you a gram negative or a gram positive organism, and he can only tell you whether it's a bacillus or a cocci. So what happens here is that if you run this test at this point of time, you will get information about the organism which is growing and the molecular markers of resistance which are detected. So look at this isolate here. This is growing Klebsiella, or this is detecting Klebsiella, and which are the markers it is detecting? SHV, CTXM, NDM, and OXA48. So we've gone through these enzymes. 2 are ESBLs, SHVs and CTXMs, and 2 are carbapenemases. So which are those? NDM and OXA48. So look at this type of a patient here. Now what will happen if I use something, let's say, like meropenem? SHV and CTXM are ESBLs, right? So they will spare meropenem. Those are not carbapenemases. But NDM and OXA48 will both destroy meropenem. So of course meropenem cannot be used. What will happen if I use an antibiotic like aztreonam? CTXM for sure will inhibit or rather hydrolyze aztreonam. OXA48, depending on the subtype, for the most part will hydrolyze aztreonam. SHV is early SHVs or generation SHVs are likely to spare it, and NDM will spare it. But of course, overall it will not work because CTXM for sure will hydrolyze it. Now, what will happen if I give this patient ceftazidime avibactam? Avibactam will take care of SHV, CTXM, and OXA48. But NDM there will remain, and NDM ultimately will hydrolyze your ceftazidime. So ultimately, at the end of the day, we want an antibiotic there to remain, which will go and kill our Klebsiella, right? Our aim here is not just to inhibit the enzymes. The aim is to actually kill the organism. So now if I give this patient ceftazidime avibactam plus aztreonam, and why am I saying this? Because right now we don't have access to aztreonam avibactam. In the next 6 months, we will have access to aztreonam avibactam. So what will happen here is that avibactam will inhibit SHV, CTXM and OXA48, and then the NDM will remain, but that NDM will not destroy your astronom. And astronom at the end of the day will go and kill your Klebsiella. Since all these years we did not have access to astronom avibactam, what is being done is that we are giving this patient ceftazidime avibactam plus astronom. So there the ceftazidime is playing a very, very questionable role. In Pseudomonas, it's a different story. But in the cases of Enterobacteriaceae, there is really no role for the ceftazidime at this point of time in such organisms. Remember, we are talking only about carbapenem resistant organisms this evening. So don't get confused with ESBL producers. So what are our options for this type of a patient? Our options include Cas-Avi plus astronom, or maybe polymyxin-based therapy, or certain other agents. So let us look at these options and how do we weigh them. So what about ceftazidime avibactam plus astronom? One good thing to do in these type of patients is to do synergy testing. So although it is good to do, there are certain caveats about synergy testing. It's the method that is being used, whether it's being standardized at this point of time. So all these things need to be taken care of. So if your lab is using the standard reference method, which now for pretty much most labs all over the world has turned into a drug elution test. So if your lab is using this type of a test, then you could have susceptibility results. Look at this. The rightmost tube is containing only ceftazidime avibactam. The middle one is containing only astronom, and the leftmost is a combination of ceftazidime avibactam plus astronom. So you will see that there is a clear, the turbidity is not there in the leftmost tube, so the bacterial growth has been inhibited if you use a combination of ceftazidime avibactam plus astronom. So look at our synergy tests in the last 6 months for Klebsiella. All 40 tests were positive, and for E.Coli about 18 were positive for the 20 out of the 25 synergy tests that were done. So which means that sometimes our E.Coli is failing this synergy test. So one thing is that it is always better to confirm with synergy testing, especially for E.Coli. How are we giving ceftazidime avibactam and astronom? So there are studies which show that simultaneous infusions are better than staggered infusions. Now we will have access to astronom avibactam soon. So astronom avibactam, one interesting thing is that the ratio of astronom to avibactam is different in this formulation. So if you look at ceftazidime avibactam and astronom, most of us are giving 2.5 grams of ceftazidime avibactam plus 2 grams of astronom, right? So in my ceftazidime avibactam, really I have only 500 milligrams of avibactam. So what we are doing right now is we are giving 2 grams of astronom with 500 milligrams of avibactam. So we are giving a ratio of 4:1. Now, the ideal ratio, which is the best suited to be a good predictor of efficacy, the best pharmacodynamic index which is achieved is actually a ratio of 3:1. So that is something that we'll have access to once we have astronom avibactam. The other option here is, of course, polymyxin-based therapy. So what are the important things here? So polymyxins are drugs, which have good gram-negative activity or exclusive gram-negative activity. Polymyxins, we must remember, there are certain organisms which are intrinsically resistant to polymyxins. So Proteus, Providentia, Morganella, Serratia, these are important Enterobacteriaceae. Again, I won't go into the atypicals or the non-fermenters right now. But if you look at some of the Enterobacteriaceae, then there are Enterobacteriaceae which are actually polymyxin resistant. And you can see a large number of organisms there in that pink circle are Enterobacteriaceae which are polymyxin resistant. So these are inherently resistant. So there's no point in testing polymyxins for these organisms. Now there are certain other organisms which are also having acquired resistance. So for example, there are studies which show that in carbapenem resistant Klebsiella, polymyxin resistance can be high. And again, the type of testing that you are doing for polymyxins is also very, very important. So again, if you do the colistin broth drug elution test, or the best test actually for polymyxins is manual broth microdilution. But manual broth microdilution for polymyxins is a cumbersome test to perform. It's a difficult substance to handle in the lab. So it sticks to the end plates. There are various phenomena like skip well phenomenon. So it's a difficult substance to handle in the lab. So the best test practically at this point of time, or a good test, I won't say the best test, but a good test practically is something known as the colistin broth drug elution test. So again, talk to your lab about the polymyxin testing that they are doing. There are various concerns related to the PKPD indices of polymyxins. And again, for the lack of time, I won't go into the details of this. So I'll skip some of these parts. But if you just look at these PD numbers, then it is very, very difficult to achieve some of these pharmacodynamic indices in our settings. So if you look at polymyxins, what we prefer is something known as an AUC to MIC ratio. Now, I'll stick to Klebsiella and E.Coli. For pulmonary infections, it is very, very difficult to optimize the pharmacodynamics of polymyxins. So no matter what kind of an AUC MIC ratio you achieve, it is very, very difficult to have good sidality from polymyxins. It is even difficult to achieve stasis for some pulmonary infections. In some of the animal models, they found it difficult to even achieve stasis for some of the pulmonary infections. So that is why there are a lot of pharmacodynamic concerns. And recently, we have been doing polymyxin levels in our settings. Now, polymyxin and the experience has been that there are very few patients who actually have ideal levels. So either the level will be too high, wherein you will have toxicodynamic concerns, or the level will be too low, wherein you will have pharmacodynamic concerns. Especially for colistin, polymyxin in that sense is a little bit more predictable. But especially for colistin, my experience has been that it is something that has very erratic levels. The problem again there is that levels of more than 2 are associated with nephrotoxicity, and there polymyxin B is a little bit better than colistin. So for polymyxins, you have two preparations, as you all know, polymyxin B and polymyxin E. In terms of PKPD, polymyxin B is a little bit better because you have a little bit more margin as far as the safety index is concerned. Whereas for colistins, you have a very narrow margin of safety. So that is one big problem. Like I said, the other problem is that even if you achieve good levels, your pharmacodynamic targets in pulmonary infections are very, very rarely met. And all these things actually were a part of why the nomenclature of polymyxins was changed from susceptible to intermediate. So now if you look at your lab reports, you will see that polymyxins are either labeled as resistant or they are labeled as intermediate. And that is to discourage the usage of polymyxin monotherapy. And like I said, a large part of that is to do with the fact that it is very, very difficult to achieve good PD indices or pharmacodynamic indices with polymyxin monotherapy, especially for pulmonary infections. So what are some of the things about polymyxin that we must remember? Like I said, there are two different preparations, polymyxin B and polymyxin E. For urinary tract infections, we should be using colistin or polymyxin E and not polymyxin B. For most other indications, polymyxin B is a little bit better. Why is it better? The AUCs achieved are a little bit better, and like I said, it has a little wider safety margin. So the nephrotoxicity is above levels of 4, whereas for colistin, the nephrotoxicity starts above levels of 2. So we have a little bit better margin or a little bit wider margin as far as safety is concerned for polymyxin B. So for urinary tract infections, use colistin. For all other infections, polymyxin B is preferred. Intrathecal therapy, the clinical experience is more with colistin as against polymyxin B. So anytime you're using local therapy, for example, inhaled therapy or intrathecal therapy, the experience is a little bit more as far as colistin is concerned. But for most systemic purposes, polymyxin B is preferred except urinary tract infections. And PKPD wise, polymyxin B is a slightly better formulation than colistin. A large part of the reason why it is so is because colistin is administered as a prodrug, right? So it has to undergo conversion into the active form. So except urinary tract infections, for most other infections, we'll prefer giving polymyxin B. But in general, polymyxin, and I skipped some of the slides on PKPDs because those are really time consuming to understand. But in a nutshell, what we must remember is that both have fairly narrow margins of safety. And in that also, colistin is slightly worse than polymyxin B. But if you do decide to use polymyxin therapy, then what are the things that we should remember? For UTIs, colistin. For non-urinary tract infections, polymyxin B. We must talk to our lab about confirming the MICs. The next question is that should we use combination therapy? The answer is that yes, you should be using combination therapies. Now almost all guidelines mention using combination therapies, especially for Enterobacteriaceae. the evidence for combination therapy is a little bit stronger than it is for non-Enterobacteriaceae. So anytime you are treating a carbapenem resistant E. coli or Klebsiella with polymyxins, combination therapy should be used. The question is not whether we should be using combination therapy. The question is which combination therapy should we be using. Now I see a lot of times that in our ICU, in our own ICU also, patients are on polymyxin plus meropenem. Now that I feel in our settings is not a useful regimen at all, because a lot of our carbapenem resistance is actually mediated through the New Delhi metallo-beta-lactamase, and that's why there are studies which show that if the MICs are more than 16, which they are invariably for NDM producing isolates, then the addition of meropenem to polymyxins doesn't really do much. So polymyxin plus meropenem is almost equivalent to giving someone polymyxin plus placebo or polymyxin monotherapy. So that's why the automatic answer is not always meropenem. Then what should we be looking at as far as deciding the combination drug is concerned? One thing that you can look at is something known as the efficacy index of an antibiotic. So what is the efficacy index of an antibiotic? It's the ratio of the MIC to the break point. So let's compare the three drugs here: tigecycline, meropenem, and fosfomycin. So again, coming back to the bigger picture, what are we trying to decide? We are trying to decide the partner drug for polymyxins for carbapenem resistant infections. So if I say that I'm going to give this patient meropenem, what is the efficacy index of meropenem here? It is MIC to break point. So 64 divided by 2, that is 32. What is the efficacy index of tigecycline here? It's 4 divided by 2, which is 2. And what is the efficacy index of fosfomycin here? It is 32 divided by 32. This CLSI breakpoint is a standard breakpoint which is defined by CLSI. So if you ask your microbiologist, he will know the answer to this question, or you can easily look it up. So now for the patient here, the efficacy index is actually the best for fosfomycin. The lower this ratio is, the better is the efficacy index, right? So now if you, even though the MICs are 4, 64 and 32, actually fosfomycin is the closest to the break point. So that's why for this particular isolate here, fosfomycin is a better choice than meropenem or tigecycline. Then the second thing that you must consider is the site of infection. So if this is a bloodstream infection, tigecycline won't be a good choice. Or if it's, let's say, a CNS infection, then again tetracyclines, or if it's a urinary tract infection, they won't be great choices. So you must anticipate the amount of the drug that is going to get into the site of infection, which is very, very important. What am I treating? Am I treating a pulmonary infection, a CNS infection, a urinary tract infection? And then I must know, how the drug that I'm using, how much of it actually gets into the site of infection. So if you consider that here, then tigecycline would be a poorer choice as against meropenem and fosfomycin. So these are some of the things that you must consider while you're choosing the partner drug. So remember, the automatic answer to this question is not polymyxin plus meropenem. In fact, I would go on to say that polymyxin plus meropenem is almost never the answer to the question that which combination therapy should be used. So again, while using polymyxin-based therapy, look at the site of infection, look at MICs relevant relative to the break point, and try and answer the question that which combination agent am I going to choose. Now the $1,000,000 question, which is better, polymyxin-based combination therapy or Cazavi-based therapy? Now we have come a long way in trying to answer this question. Initially, there were studies, and this was a fairly large study which was known as the Crackle study, but this unfortunately did not have NDM producing isolates, and they looked at colistin versus ceftazidime avibactam in the treatment of infections due to carbapenem resistant Enterobacteriaceae. Very few of the isolates were NDM producers. Now we published something a couple of years back which showed that ceftazidime avibactam plus or minus aztreonam actually had better outcomes as against polymyxin based therapy. And then we also, so this was the study that we published, and then we also published a meta-analysis which showed that, for NDM producers, and this is important because NDM production is very, very common in our settings. So now it looks as if, ceftazidime avibactam plus or minus aztreonam. Why do we say plus or minus? If class B enzymes are being produced, then you will have to add aztreonam. If class B enzymes are not being produced, then it's only ceftazidime avibactam monotherapy. So ceftazidime avibactam plus or minus aztreonam has better evidence than polymyxin based even combination therapy, and that's why in our study we were careful to compare ceftazidime avibactam plus aztreonam versus polymyxin-based combination therapy. Because if I compare it with polymyxin-based monotherapy, then of course it is not going to look as good, because I already showed you that the evidence for combination therapy is better. So how do we summarize the evidence so far, or also summarize what we have discussed so far? We'll say that, if you are treating E. coli or Klebsiella, there are 6 main enzymes that you're likely to encounter in our settings. 3 are ESBLs, which are those 3, CTXM, SHV, and TEM, and 3 are carbapenemases, which are those KPC, NDM, and OXA48. If you look at all the BLIs that we have right now, by far the most potent is avibactam. And out of these 6, except NDM, avibactam is able to inhibit all of them. So SHV, CTXM, TEM, KPC, and OXA48. All these 5 out of the 6, avibactam is able to inhibit. If you have a carbapenem resistant Enterobacteriaceae, the chances, if you have a class B enzyme production, then you will need Astronam along with ceftazidime avibactam. If there is no class B production or class B enzyme production, then ceftazidime avibactam monotherapy will be sufficient. If you are using polymyxins, be very, very careful about the MICs of polymyxins, about which formulation to choose, how to dose the patients, and how to monitor for toxicities. If you are treating carbapenem resistant Enterobacteriaceae with polymyxins, remember, combination therapy is recommended over monotherapy. And combination always does not mean polymyxin plus meropenem. You have to choose the partner drug based on the site of infection as well as the MICs relevant to the breakpoints. Now, look at this patient here. He came in with emphysematous pyelonephritis. Here, E. coli in blood, and it was carbapenem resistant. So you can see from here that Astronam is resistant. Ceftazidime avibactam was also resistant. So we have NDM production. Why? Because Cas-Avi is resistant, but Astronam is also resistant. So which means that we have another enzyme in addition to NDM. So this could be something like an NDM plus CTXM or NDM plus OXA48. Many different combinations are possible. We can conclude from this that this is very likely to be a multiple enzyme producer. Now, so what would you choose for this patient? You would normally choose something like a Cas-Avi plus Astronam. Now, surprisingly, Cas-Avi plus Astronam synergy was not detected. I showed you in the beginning that this is one of those 7 patients. I showed you 18 out of the 25 patients have had synergy being detected. So, there are a few patients in whom this synergy will fail for E. coli. There are various reasons. The most commonly thought reason is something known as PBP3 modification. I'll talk a little bit about that. So if your final target, so Astronam's final target is penicillin binding protein 3. If that is mutated or modified, you could see this type of a pattern. That's not the only reason why synergy fails. There are many other reasons. Again, I won't confuse you by going into the details of why synergy tests fail. But rarely you can have a synergy failure. What was worse was that the manual test showed a high colistin MIC. So this is a difficult situation. So you can have PBP3 mutations which render the combination of ceftazidime avibactam plus Astronam resistant. Till now, the PBP3 mutations have been described only in conjunction with other enzymes. So we will not have an isolated PBP3 insert which is raising the MIC of Astronam avibactam. It will always be in conjunction, and CMYs are plus NDM is thought to be the commonest combination which is increasing the MICs. So phosphomycin-based therapy can be thought of. Phosphomycin is a good drug for E. coli, especially, and even monotherapy can be thought of, not in sick patients, but in stable patients, definitely monotherapy can be thought of. I have had quite a number of patients in whom I've used phosphomycin monotherapy for carbapenem-resistant E. coli. The reason is that phospho is a very good drug for E. coli. If you look at the MIC90s of phosphomycin, they are fairly low for E. coli as against Klebsiella. So for Klebsiella, you will not recommend using phospho monotherapy for carbapenem-resistant Kleb. But for E. coli, definitely it can be thought of. So here we had no option but to use phosphomycin. We might soon have plasmomycin. So plasmomycin, especially for E. coli, might be something to test. I don't think it's going to add anything for the other organisms in India. But for E. coli, especially PBP3 producing, wherein you have the failure of Astronam avibactam, it's something to be tested. And then cefepime zidibactam, again, hopefully by early next year, the way things are going right now, I think we are on course for getting access to it early next year. So cefepime zidibactam again will be a drug that can resist PBP3 mediated or PBP3 mutated failure. The reason is that Bactam itself is also it also has antibacterial properties, and those are not through PBP3. So what is the spectrum of fosfomycin? So coming to the basics, fosfomycin has become an important drug in our repertoire at this point of time. So if you look at fosfomycin in a nutshell, it has broad spectrum coverage. It has gram-negative as well as gram-positive coverage. In fact, there are studies which have looked into using fosfomycin as combination therapy for MRSA. It has good enterococcal activity. It doesn't have great streptococcal activity, but it does have quite broad gram-positive coverage. Amongst the gram-negatives, like I said, for E. coli, it is excellent. For Klebsiella, it should not be used as monotherapy for bacteremias. For Pseudomonas, definitely should not be used as monotherapy. Lab will not even test for it, and Acinetobacter does not have any activity. So that's why for this particular patient, what we did was that we used a combination of high dose colistin plus fosfomycin. Of course, with emphysematous pyelonephritis, the most important thing is to get your urologist to intervene. So like I said, the MICs for fosfomycin are much lower for E. coli than they are for Klebsiella. The other good part is that fosfomycin is a drug that penetrates well into different body sites. So whether it's the urinary system, lungs, CNS, usually you will have good penetration of fosfomycin. So there is there aren't too many sites wherein the site of infection is a limiting factor for fosfomycin efficacy. Whereas if you look at tigecycline, it has excellent penetration into the GI tract or for intra-abdominal infections and for skin and soft tissue and bone infections. For lungs, not as much as for GI and skin and soft tissue, and definitely not something to be used for bloodstream infections. For amikacin, again, there are concerns with the CNS penetration as well as pulmonary penetration, as well as abscess penetration. These are three particularly worrying situations as far as using amikacin is concerned. And now they've also lowered the amikacin breakpoint. So be very, very careful when you are using amikacin monotherapies for your carbapenem resistant organisms. Minocycline again is something that can be thought of, but be mindful of the MICs, and definitely MICs above 2 and for sure MICs above 4 require higher doses of minocycline to be used. So we should not be fixated on the 100 milligram BD dose of minocycline that we use for all the patients. So if I had to summarize, carbapenem resistant enterobacterial infections or E. coli and Kleb, which is what we are supposed to talk about tonight, then we can say that for the most part, if NDM is being produced with some other enzyme, ceftazidime avibactam plus aztreonam remains a good choice. In the rare case that it fails, you have polymyxin-based therapies to fall back on. Phospho is a good choice for E. coli, so that is something that you can make use of. Remember, when you are using polymyxins, use combination therapy for carbapenem-resistant organisms, and the automatic answer is never polymyxin plus meropenem. In fact, that's not a good regimen at all for our isolates. And when you're trying to choose the partner drug, look at various factors like the MICs relative to the breakpoint and the site of infection. So let us look at a few cases for the next maybe 10 minutes or so, and then we'll stop. If you look at Klebsiella, so this was Klebsiella in blood cultures resistant to ceftriaxone, cefepime, resistant to imipenem, and susceptible to meropenem. What is the mechanism and what will you do? So here we come to distinguish between an important concept: carbapenem resistant enterobacteriaceae versus carbapenemase producing enterobacteriaceae. So right now, when I show you only this, you don't know whether this is a carbapenemase producing enterobacteriaceae. So what is a carbapenemase producing enterobacteriaceae? Something that produces the carbapenemase enzymes. Whereas even if any one out of the three or four carbapenems that we use in clinical practice is resistant, you can call it a carbapenem resistant isolate. So guidelines recommend that if you have access to genotypic testing, do get it done. If it's a carbapenemase producer, it's best to avoid all carbapenems. But if it's not a carbapenemase producer, then you can go ahead with the susceptible carbapenem. Now, E. coli and CSF in a post-neurosurgical meningitis patient, resistant to ceftriaxone, cefepime, resistant to imipenem and meropenem. This is a patient that we had last year. Now, the Cas-Avi-Aztreonam synergy failed. So again, it was a very difficult situation, similar to the emphysematous pyelonephritis case that I showed you. However, the other challenging thing here is the local penetration of polymyxin. At least there we could use high-dose colistin it does get well into the geo tract. Now the MICs were high, so even that pyelonephritis case was a challenging case. But here it gets even worse because now the synergy has failed, and normally you would have relied on a polymyxin backbone. That becomes a poor choice for CNS infections. So this is something wherein we had to use high dose phosphomycin with, of course, IV plus intraventricular colistin. So that's why the IDSA guidelines are saying that if you have an NDM producing isolate, then ceftazidime-avibactam in combination with aztreonam should be used. Ceftazidime, although the guidelines advocate, has been rapidly falling out of favor because of a large number of or a large in vitro resistance data that has been generated world over. If we would have had time, I would have showed you ceftazidime data in greater detail, but I think ceftazidime is another presentation. It might take at least half an hour to go into the ceftazidime details. What are the preferred antibiotics if you have OXA48 producing isolates? Then of course we said that if you have KPC or OXA48 producing isolates, then only ceftazidime-avibactam can be used. Last but not the least, we will have access to cefepime-zidibactam soon. Now it's a good drug because zidibactam itself has antibacterial properties. So it has been shown to be susceptible even in the face of NDM production or PBP3 mutation. And cefderichol is an interesting drug. Theoretically, it's not destroyed by NDM, and it's also not affected by some of the other non-enzymatic mechanisms because it is a cephalosporin siderophore, or it is a siderophore cephalosporin. I will skip the cefderichol resistance part. So we can conclude by saying that always think of which bug, which site, and which is the resistance mechanism involved, and attempt to get maximum information up front from the lab. MICs, additional antibiotics, enzymes involved. Know the BLI spectrum, what can avibactam cover, what can tazobactam cover, and so on. Think of all aspects of combination therapy. Remember that when you're using polymyxins for carbapenem resistant isolates, you should be using combination therapy. But the automatic answer is not polymyxins plus meropenem. And choose the combination drug based on the site of infection as well as the MICs relative to the breakpoint. Know the right dosing strategies. So, the dosing for phosphomycin, dosing for minocycline. There are many things that need to be looked at when you're trying to dose these type of drugs. And that is why get help from your microbiology, ID, and pharmacy colleagues. So I think with this, I will stop sharing. If there are any questions, then I think we can open the house for a couple of questions.
Yeah, from the house, if anyone has any query or questions, please feel free to ask. We have not received any questions or query in chat box. I will just wait for another 30 seconds, and if someone has any query or questions, so please feel free to ask. Otherwise, we will close, and if you have any query or questions, you can drop a message to us and we will convey this to sir. So one question is raised by Dr. Ankit Rimal. Why is polymyxin B and meropenem and a bad combination?
So bad in the sense that meropenem doesn't add much to polymyxin for our isolates. So if you look at the NDM producers which have a very high MIC and many of the other carbapenems also raise meropenem MIC to quite an extent, then it has been shown in studies that once the meropenem MICs are really that high, if you have intermediate MICs for meropenem, then it can be a good combination. But once you have high MICs for meropenem, adding meropenem to polymyxin doesn't really add much to the monotherapy regimen. There are similar very big studies for acinato as well, in which they showed that colistin plus meropenem was almost equivalent to colistin plus placebo. So that's why you are not really getting that much of an advantage with this type of a combination as far as um, treating carbapenem resistant enterobacteria are concerned. So the other combination regimens are much better. For example, looking at, like I said, tigecycline or minocycline or fosfomycin, and these type of combination regimens, of course, in addition to polymyxin. So here we are talking about, when you're trying to treat someone who with a carbapenem resistant enterobacteria with polymyxin based regimens. There, poly plus mero doesn't really add much over poly monotherapy. Yes, so the nomenclature changed. Before they were reporting colistin with MICs less than 2 as sensitive. Now CLSI has changed it to either intermediate or resistant. And there are a few issues with that. One is that, of course, testing is difficult, like I said. The other part here is that, if you look at the pharmacodynamic targets for especially pulmonary infections, then they are almost impossible to meet with monotherapy. And even for bloodstream infections for Klebsiella, animal models have shown that it is very, very difficult to achieve a 2-log kill. So in simple words, it is very, very difficult to optimize the pharmacodynamics of colistin or polymyxin, and that's why they have stopped using the word susceptible. They are either reporting it as intermediate or resistant. So the same the thing that they were calling susceptible before, now they are calling it as intermediate. How to tackle NDMs? So NDMs, like we discussed, are class B enzymes. They are metallo-beta-lactamases. Right now, we don't have a BLI which can inhibit the New Delhi metallo-beta-lactamase. Like I said, taniborbactam will be perhaps the first that we'll have access to in terms of having a BLI that can inhibit the New Delhi metallo-beta-lactamase. For now, all the BLIs that are there, clavulanate, sulbactam, tazobactam, enmetazobactam, avibactam, relibactam, vibobactam, none of them can inhibit the New Delhi metallo-beta-lactamase, not even zidibactam. Zidibactam itself cannot inhibit the New Delhi metallo-beta-lactamase. So how to tackle it? The good part about NDM, if there is any, is that it spares the monobactam. So aztreonam is spared. So one strategy is to use aztreonam. If there are other enzymes in addition to NDM being produced, you could use avibactam to take care of those enzymes. So for example, NDM plus CTXM, then we use the avibactam to take care of the CTXM. So one part here is using avibactam plus aztreonam plus avibactam. If that fails, so for example, I showed you some cases in which the synergy also can fail. If the synergy fails, or if now we'll have access to aztreonam avibactam testing, if that fails, then polymyxin based combination therapy, either looking at something like tigecycline or fosfomycin or minocycline in conjunction with polymyxins. Cefepime zidibactam is something to look forward to, because like I said, although zidibactam does not really inhibit New Delhi metallo-beta-lactamase, zidibactam itself has antibacterial properties. So it is a bacterial enhancer. So it has antibacterial properties. So many of the NDM producing isolates have actually in vitro shown good MICs as far as cefepime zidibactam is concerned. And plasmomycin also we might have access to. Rarely for carbapenem is producing E.Coli, it also will be, it may be susceptible. So these are some of the options: polymyxin based combination therapies, cefepime zidibactam in the future, and of course aztreonam avibactam right now, subject to testing. These are the good ways of tackling NDM. Yes, Dr. Hitesh, I showed you our own data. We have, it is very, very highly prevalent amongst carbapenem resistant isolates. And we had published that a couple of years ago. Amongst carbapenem resistant isolates, we have almost a 50% prevalence of NDM. So almost 50% of our carbapenem resistant Klebsiella and more than 70% of our carbapenem resistant E.Coli, they produce NDMs. Yeah, sure, we can share that with you. this was the flowchart. Basically, the gist of what we have discussed so far, that if it's an NDM producing isolate, you will need aztreonam. If there are multiple enzymes, you will need avibactam in addition to aztreonam. For E. coli, even the combination can sometimes fail. The other options are polymyxin B based combination therapy, like I've been saying again and again, combination over mono, and poly plus mero, not really a great combination in our settings. The other drugs to look into are tetracyclines and phosphomycin. Phosphomycin, especially for E. coli, is a good drug.
Any last question from the audience?
Okay, I think let's close if there are no further questions.
Yeah, so I think it was really a nice presentation and the discussion regarding CPKP, CRKP, and NDM. So let's close it here and call for this meeting. Thank you so much, sir, for your valuable time. And on behalf of our entire team of Pollen, we'd like to say thanks to you.